Doing pretty well.
Here, the roads are a lot better today, which is good.
Good morning.
Good morning. All right. Can you guys see the screen okay now? I tried to hide some panels. You guys got a good
Yep.
view?
Yeah,
Yeah,
Okay.
we
we
can
can see
see
it.
it.
All right. This is a little bit of a lengthy talk, so I'll do the best I can to plow through it. Um, so I know it seems weird when we just got hammered with a foot of snow to be talking about baseball. But Ohioans are super weird and they're all starting like indoor baseball training this week. So I know it seems kind of weird to be talking about being outside and throwing the baseball, but there will be lots of kids indoors throwing the baseball, and a lot of these kids have not thrown the baseball in a while. So it will be in the next few weeks that we start seeing kids with baseball related injuries, which to me is just odd, but that's the way these athletes roll. So we're going to kind of go through a little bit of an intro. We're going to talk about throwing motion, really important history questions for you guys to get used to asking because it helps us when we're assessing these kids. Important things to look for in physical exam. And then the bulk of the talk is really talking about like specific shoulder and elbow problems that happen from throwing. We'll touch on a little bit of interval throwing programs. I updated my talk this week to try and reflect a couple concepts that were on my CAQ in regards to these topics. And I threw in a couple questions at the end that kind of mirror what I was asked. So if we have time, we'll hit those. That being said, the CAQ variability is kind of wide. Like I took it at the same time as two of our fellows, and we walked out of there and started talking questions, and we had not as much overlap as I would have predicted. But hopefully this will help you guys. I'm also chugging my hot coffee, so bear with me. So there's well over 5 million kids who play true baseball at this point. That is not softball. And most of the injuries that we're going to talk about today are really overhand throwing specific. So they don't really apply as much to softball pitching. They really apply to overhead throwing. So we'll see some softball kids get similar pain from overhead throwing, but more than anything, this is baseball. So even in Ohio, it's virtually a year-round sport. So they start indoor throwing January, February. They work outdoors as soon as they can, March or April. And then there's usually spring seasons at the school level in April and May, or at the rec level, they'll run like April through July. And then the high school kids, we usually have a summer league that runs June through August. And then there's oftentimes a fall season where kids will play September, October. And November, December, if there's going to be a time off of throwing, is when that is. But there is an extremely high amount of indoor training now that these kids have access to. Even if you just looked into the T3 space after work, you've probably seen baseball kids in there throwing and hitting and pitching. So the main complaint we see for people is elbow pain in that 9 to 12-year-old range. And then just above that age range, working more 13 and higher, the pain tends to move to the shoulder, but we still see shoulder pain in younger kids and elbow pain in older kids. And it's directly linked to throwing volume. So, back when I was in training, all they talked about was breaking balls. They loved talking about curves and sliders and how you shouldn't throw a curveball until you could shave was the common teaching. And they said that because it had to do with growth plate closure at the elbow. And when the hand was throwing a traditional curveball, it was really doing a big rotational force around the ball. And you just don't see that as much anymore. A traditional curve, most people don't throw now until their teen years, but there are some modified ways of throwing it. So if you're asking kids about pitches they're throwing and they say they're throwing something that's an off-speed pitch, I usually ask them to show me how they throw it. And it's much more common now for people to do what's kind of pictured in this image, where their hands along the side of the ball and they're really just moving from a position of radial deviation into forced ulnar deviation, kind of coming right down the side of the ball as opposed to rotating around it. And this does not seem to be as risky, but it's good to know, one, because of the history, and two, because if you're asking people about throwing pitches, you want to ask kind of how they're throwing them to determine their risk. So, uh, obviously, higher velocity and longer distance throws put people at increased risk. And we've really moved into an era where we talk about decreasing pitch counts. There's recommendations that are very specific on the boys' side of the sport and really trying to convince people to save their arm. There's virtually no professional baseball player who was a high-level youth baseball pitcher. Most of the guys who are pitchers are kids who really didn't start pitching high volume until later in their life. And the problem is that the kids who are good at pitching young get overthrown. So we have a big problem. There are rules. Both USA Baseball and Little League have pitch count rules, and I really recommend you guys take 2 minutes to go to both websites and look them up. They're pretty similar. I do even have like a table that you can drop into Epic for patients. That's just, I think it's .psm Little League, and it actually drops in the throwing pitch counts that are recommended. But these are really meant to be pitch counts that give you recommendations on how often you should be throwing and how many pitches you should be throwing. And the important thing is to ask people, do you follow pitch count recommendations? And if they say yes, say, okay, so what's your usual number of days off and what's your usual number of throws? And then I always ask people, if they're playing on one team, do they take their pitch counts from one team to another? Because I've literally had kids who play on two teams who pitch count on two teams, but they don't share the data between the two teams. So they're actually doing double what they should. So you want to ask people about this closely. And some people actually do pitch counts, but they don't then remove people when they hit their maximum number of pitches. So it's really important to ask like specific questions. So here's like the USA Baseball one. So you can see it's really age specific for how many daily max pitches you should be throwing. And then based on the number of throws you make, how many days off should you have? So if you're an 11 and 12-year-old, you shouldn't throw more than 85 pitches in a day. If you do throw up between 66 and 85, you should be taking a full 4 days off. But if you come in as a reliever and you only throw 18, you can go back out and throw the next day. So it's helpful to have this table to kind of know what to do with people.
I would
So,
add to that to ask when athletes come off the mound, what do they then do? Like if they're going to a different position, and especially
yeah,
if they're going to catcher, that's a lot of volume too.
yeah, that's in my history questions coming up. It's super true. We try and really capture as much of the detail for what they're doing as possible. This is probably one of the areas where those history questions are more specific than in other sports. That's why I like to give this talk now. Here's the throwing motion. The baseball throwing motion is split into 6 separate phases. You're going to want to kind of learn what the different phases are, what the hallmark of each phase is, and what structure is at increased risk based on the phase. It's really important. From a history perspective, we always ask, like, in what phase of throwing do you feel the pain? It's really important to find out, is it that acceleration phase, which is typically the most common, or is it more follow through? Like, when are you getting the pain? So the highest at-risk position for the elbow is that late cocking, and then actually when you're decelerating. So moving on, these were two specific questions I had on my test. They asked, what is the fixed restraint and maximum external rotation at the shoulder? And the answer is the inferior glenohumeral ligament. And then the other question I got is, what elbow structure is at risk of injury in follow through? And I can't remember what my other options were, but I narrowed it down to olecranon fossa. They asked, there's definitely questions about like baseball players having pain in full extension at release. And it almost always had to do with an injury at the olecranon, and you'll see that come up in practice questions. Oh, here's Sousa's fairly decent ability to capture what a softball windmill motion looks like for one of our case pitchers many years ago. I had to write an article about softball injuries, and the softball pitching motion is very different. So it's obviously underhand. The structures that are at risk are very different. We do not see nearly as many complaints about people throwing like this. When we do, it's almost always biceps tendonitis from that deceleration coming through. I rarely see many other complaints with this. So the throwing motion is like a super delicate balance. We want to obviously have laxity within the joint because that gives us range of motion to hit a large amount of external rotation. But at the same time, we need to have stability within the joint to prevent ourselves from subluxing or dislocating when we're in that maximal range of motion. And we have to have the strength to hold the humerus in the glenoid as we accelerate through. So for kids who are too lax, we see problems, and for kids who are too weak, we see problems. And so those are really the things you're trying to assess when you do your physical. The other thing we look at is the kinetic chain. So we are mainly generating our force when we throw from our legs and our core, and you're just transferring it from that proximal portion of our body into the distal segments. So if you have video of the kids, if the parents have video of the kids throwing, I usually ask to see it, and you see lots and lots and lots of young kids just literally throw from the arm, and they just whip it at the elbow and wrist. And so there's a lot of pain that happens in that situation until you learn to generate your force from your body and just transfer that force distally, you will have problems. So a lot of times when we're examining these kids, it's super important with elbow kids that you look at their shoulder and scapula and core. And it's super important for the shoulder kids that you're assessing that core. A lot of times I'll even look all the way down to hip strength. So it's really important to think about joints more proximal to where the pain is. The position of the scapula is really important. If your position of the scapula isn't kind of flush against the rib cage and it doesn't move smoothly without winging, you almost always end up with problems at the shoulder joint with throwing. So you have to really think about having strong enough scapular stabilizers to tether it down properly. And if you do, it allows the rotator cuff musculature to work much more efficiently. For kids who tend to have scapular winging, like everybody who's never been strengthened posteriorly does, they tend to get problems with their rotator cuff fatiguing earlier, which leads to pain. I added this slide because they love asking about scapular winging on the CAQ. I did not have a picture at all. I literally had a description. So there's three different kinds of scapular winging that can happen from nerve impingement. So this is really different than just like I'm weak and I've never strengthened my scapula. This is like true nerve impingement causing scapular winging. So the one on my test was a spinal accessory one. I put that up top. There's really two kinds of scapular winging that these cause. Lateral scapular winging, where the outer border is more prominent, and then long thoracic can cause a medial scapular winging, where the inner border is more prominent. So again, you're going to want to kind of look these up individually to see photos, although I was never asked. Based on an image, I was given a description. So I was given a description of somebody who had lateral scapular winging who was unable to shrug on the affected side. So if you can remember spinal and dorsal, for me, like I try and come up with dumb mnemonics. So for me, spinal and dorsal both have an L in them. So I remembered, and the L's at the end for those. So they match up and they have the same winging pattern. So lateral winging, the L's at the end and they match up. Long thoracic is the other one. So for me, that's medial. So that's the only way I can remember it. I got to just write these things down over and over and do flashcards a million times to remember things like this. But this pure memorization of anatomical issues will get you far on the CAQ. So dorsal scapular causes the same type of winging, but it's rhomboid weakness. So you get increased winging when you attempt to elevate the arm. And then long thoracic weakness affects the serratus anterior. So this one is most obvious with, they describe it always with arm flexion. So with arm flexion, you get increased winging. On exam in the office, we often try and bring it out with wall push-ups. So when you're doing a history, really important questions you want to ask, like at what age did you start pitching? How many years have you been pitching for? How many times a year do you typically throw? It's crazy. Sometimes you'll ask people that, and I've literally had 12-year-olds tell me that they play like over 85 games a year. It's like they think they're the Cleveland Guardians. It's insane the volume that these kids play. You want to ask how many teams they're playing on at the same time. It's super common for kids to double up and play rec and travel. It's just super common. Number of pitches in outing, number of rest days between outings. Are your pitch counts tracked? Do you carry them over team to team? And then how much rest do you have between seasons? We really, really, really try and get kids to always take off a minimum of 2 weeks at the end of the season. I really try and get baseball kids to take off a month from throwing, but it is hard. But like swimmers, same thing. I try and get them to do 2 weeks off after high school and 2 weeks off after club. And if you can get these kids to do breaks like that, they do much, much better. And then you're going to want to ask about what types of pitches they're throwing, if they're throwing anything off speed, ask at what age they threw it and the grip on the ball. How many fastballs do they throw relative to the off speed balls? And then a history of prior pain. It is crazy how many kids you see who are like, oh, yeah, I had elbow pain the last 2 seasons. So it's a big recurrent issue. And that's something we talk about once we get kids better. Like, if you don't keep up with your exercises, you will be back in here next year having the same pain. So, talking about prior seasons and if they've had anything similar or any other throwing injuries in the past at the shoulder or elbow. And then we also try and talk about a history of missed outings. Like, are you having to get pulled off the mound? How long can you throw for before the pain comes on? Does it happen right away? When the pain starts, do you come out right away? I always ask if they're working with a pitching coach, if they've had their mechanics changed at any time. So there's just a lot of detailed history questions. And we should probably just come up with throwers history form and drop it into Epic. So when we're bored this week in clinic, somebody remind me. So this kind of gets at the more specifics I was just mentioning. Where does it hurt? How long does it last? Does it radiate? Um, and then are you getting it early in the game or is it happening later? When in the throwing motion do you feel it? And then I always ask about change in velocity or endurance, any feelings of tightness, any neurovascular changes. You can't have people get swelling or change in vascular pattern in the arm. So you want to ask details about that. And then is it at the point where it's causing any problems outside of baseball? Does it hurt when you're lifting up the big milk carton or your backpack? Have you had loss of motion, any sense of instability, any problems with strength? And then we move on to our typical physical exam, which at this point you guys are pretty good at. So range of motion, strength, inspection, palpation, all of our special tests, a good neuro exam, vascular exam, and skin exam. It's really important to lay these kids down when you're doing your range of motion and remember that your total motion should be 180 degrees between internal and external, and that most throwers on their dominant arm will have an increase in their external range of motion and a loss of internal range of motion. And that loss of internal range of motion is really important to assess because sometimes we'll see people with what we call glenohumeral internal rotation deficit, which we'll hit on in a slide in a few. So you really want to think about the anatomy of the shoulder, and this stuff's pretty straightforward for you guys, but just kind of knowing where the basic landmarks are for the rotator cuff. And then looking at things from this perspective, one of the things we're going to touch on is quadrangular space syndrome, which is something that clinically we never discuss, but they love on the CAQ. So we'll talk a little bit about that and thinking about the anatomy. Okay. So, extrinsic wise, when we're thinking about the differential diagnosis of things that can lead to shoulder pain, you're thinking about rotator cuff tendonitis. A lot of people, especially baseball dads, bring their kids in and are like, oh, I'm sure Johnny tore his rotator cuff. And I can tell you the number of rotator cuff partial tears I've seen in 20 years amount to maybe two. It's super rare for kids to have rotator cuff tears. They are not adults. Um, Subacromial impingement, super common. Little league shoulder, super common. And then scapular dysfunction. For me, clinically, I just think about kids as having scapular dysfunction. I don't really get too caught up in all the different subcategories of it. You will see kids with snapping scapula. There's definitely a scapulothoracic bursitis. We have different varieties of the scapular winging that can be due to nerve impingement, as we mentioned. And then really like the most common thing we see is probably sick scapula, but in my mind, I'm just calling this scapular dysfunction. But so you guys know clinically, scapular dysfunction can be broken down into different categories. And diagnostically, sick scapula is something we probably see on a common basis and just don't name. So it's really scapular malposition with that inferior medial border being prominent. They get a little bit of coracoid pain occasionally. And the biggest thing is they get dyskinesis of scapular movement. So when you're having them go arms up overhead repetitively, you'll see the scapula. A lot of people describe it as like cogwheeling, or it's just kind of like jerky with its motion. This guy should be old hat for you guys when you're thinking about tendonitis or impingement. You're looking for diffuse pain, weakness, decrease in velocity. Most of the time, you're talking about strengthening these kids. It's not until they're done growing that we even discuss any sort of corticosteroid injection. And for older kids, if you're seeing college age kids, certainly a corticosteroid injection is reasonable. And if you do see anybody with a complete tear, then you're talking about surgery. Little league shoulder is the more specific thing that we can see in clinic. So you're talking about pain in that proximal humeral epiphysis. And some people call it proximal humeral epiphysitis. It's really a Salter Harris 1 of that proximal humerus. And kids get it when the humerus is open. It's typically in the early teen years. It can happen with any overhead sport. They will have pain with throwing. They will have persistent achiness. They will have loss of control and velocity. And they tend to present as somebody who almost looks like somebody with impingement. They're a little bit more tender right at the head of the humerus, but they hurt with overhead motion. They hurt with abduction. They hurt with activating the supraspinatus. They'll hurt in apprehension, which mimics that cocking phase. And some of us do get comparison views. I don't routinely get them. Um, some people will start by getting the affected shoulder. If they're not sure, then they'll get the asymptomatic side for comparison. I oftentimes just get the symptomatic side. And then if there's a diagnostic concern, or a lot of times if they're mid-season and I think I need to shut them down, but I'm not positive, I always offer MRI for diagnostic clarity because when you shut these kids down, you got to shut them down for a long time. So here's one of my patients, and you can see kind of that humeral. Can you guys see my mouse okay?
Yeah, we can see it.
All right, so right in here is the physis kind of coming across, and look at how crazy wide they are right here, okay? So if you're not sure if that's normal or not, you just get the other shoulder and you compare them. Back in the old day, we actually had film that was printed, and I was taught in fellowship to take the affected shoulder and the unaffected shoulder and flip the x-rays on top of each other and see which growth plate was wider. We don't do that now. When you MRI them, a lot of times if you have subtle widening, you can't tell on x-ray, but if you MRI them, you see the fluid within that growth plate, and then you know, okay, we got a big problem here because that's a significant amount of fluid. A lot of times you'll see fluid around the growth plate into the remainder of the bone also. And then intrinsic shoulder problems, you want to think about bony problems. So here you're thinking about a bony Bankart. You're thinking about an OCD in the shoulder, which is extremely rare. I have never seen one, but they do say that you can get an OCD in your glenoid. The older folks, obviously, osteoarthritis is number one. There is something called Bennett's lesion, which clinically we don't tend to see on the ped side, but the adult side you can see it, where you get mineralization, that posterior inferior glenoid, and it can cause some capsular traction. That capsular traction causes like a reactive bone formation, so you get like this prominent area, that inferior glenoid. And then biceps tendonitis, tendinopathy, super common to see, especially in softball kids. So when you're thinking about all those different labral injuries that can happen, we think about in throwers, a slap tear being the most common. So that superior labrum, that tears from anterior to posterior. For this, you're doing a 3T MRI to get a good look. You can have just a soft tissue Bankart as opposed to a bony Bankart lesion, which causes that anterior instability. You can see a posterior labral tear. This is bolded because they like to ask about posterior labral tears on CAQs. I don't know why. It results in posterior instability. And then super rare is a humeral avulsion, the glenohumeral ligament, or what we call a Hagel lesion. I see this not even once a year. It's pretty rare. We see a lot of kids with multidirectional instability and then glenohumeral internal rotation deficit. Okay, so when you're thinking about the anatomy, this helps you a little bit. At the bottom is that inferior glenohumeral ligament, which we talked about being the static restraint in the shoulder. But like I said, we do see injuries to other structures. Here's another good anatomy picture so you can kind of think about how these present in terms of where their pain is. And then kind of going through them. So your SLAP lesion is that detachment of that glenoid labrum biceps complex from the glenoid rim. The most common one we see in throwers is a type 2 where you get a peel back lesion. So there, that biceps anchor literally just pulls back that superior part of the labrum. But occasionally you'll see a bucket handle, or more commonly, we just see like fraying of the superior labrum where the biceps attaches. So that's a soft tissue SLAP. So on MRI or on arthroscopy, you can really see that pretty picture at the bottom there, how that biceps just really pulls that labrum away from the glenoid. So we have two varieties of that Bankart. To reiterate, bony, you get a glenoid rim fracture, much less common in a thrower, much more common with a traumatic dislocation. And then that fibrous, no bony involvement, it's that anterior inferior glenoid labrum torn. So it's weird they're both called Bankart lesions because they're occurring in different parts of the labrum. So it's important to just remember that there are really two separate Bankart type problems in the shoulder. And we see Hill-Sachs associated predominantly with the bony traumatic, but you can see Hill-Sachs lesions with fibrous at times. So here's some pictures of more the fibrous variety. Hagel, not common. Here's what it looks like, where you have that avulsed humeral, the humeral avulsion, the inferior glenohumeral ligament. And again, this is your static restraint and external rotation, so it makes sense that it could be injured in throwing. We will see glenohumeral internal rotation deficits. So a lot of times you'll have that loss of internal rotation. It's really important to assess both shoulders in everybody. You want to look at, do you have a complete 180 degrees? On that dominant side, you're going to have increased external rotation and loss of internal rotation. But if you still have 180 degrees, you're good to go. If you don't, then we're talking about a loss of internal rotation. It can be more associated with a SLAP lesion. And you want to think about getting these kids going with a sleeper stretch as soon as you can, because we see a lot of shoulder pain from that loss of internal rotation. And then other things to think about in the differential diagnosis, for sure, some neurovascular things. They are much less common, but much more concerning a lot of times. So we'll see kids with thoracic outlet syndrome, especially the softball kids, I think, tend to have it more than the baseball kids. And then the one thing we're always trying to rule out is like an axillary artery thrombosis or an effort thrombosis. And then we're going to talk a little bit about quadrilateral space syndrome and suprascapular nerve palsy because those are two hot CAQ topics. I don't know why, but they love asking about it. I got asked about both again this year. I think I've been asked every single CAQ about those two things. And then brachial neuritis. So thinking about the structures, just remember all those neurovascular structures are traveling under the clavicle, and we see problems with that axillary artery with acute dislocations in the shoulder because of where it travels. So make sure you're assessing for sensation across that Sargent's patch, and then make sure that you're always doing a good distal neurovascular exam. So although we're assessing elbow and shoulder, we still need to look at wrist and hand for strength and sensation. And then from a neurovascular perspective, super common to get compressed because of tight pecs. So that pec minor can really compress a lot of vascular structures, but we'll see kids with some scalene compression and occasionally a first rib. So when we have neurovascular compression, it's not uncommon to just do like an AP cervical x-ray. When you're thinking about neurovascular problem, sometimes you'll hear more about like fatigue in the arm in a sense of like a heaviness or achiness as opposed to pain. The pain can be much more vague. It won't be isolated to a specific spot. They may describe just kind of loss of velocity. So the symptoms tend to be more vague. They can occasionally have some nerve dysfunction with loss of grip strength or dexterity, but that's pretty rare. When you're talking about arterial versus venous, oh, look at this. I have subclavian and axillary flipped. So arterial is axillary compression. You get coldness and pallor. Venous, you're talking about that subclavian getting compressed. You can have swelling and mottling. Oh, and my computer locked. Hold, please. Not sure why. I guess it was just time to lock. All right. My computer is recurrently locking at that slide. I don't know why. That is odd. Let me see if I can manually advance here. All right, we will advance this way then. Don't know why it's doing that. Let's see if I can hide the controls again. So for axillary artery, can you guys see the screen okay still?
Yeah.
So for axillary artery, it's at risk for thrombosis because of compression. Occasionally that humeral head, but oftentimes that pec minor. And then when you're looking for this, it is hard to pick up. So if you're worried at all about a thrombosis, venography is a gold standard. We rarely do that. Most of the time we start with an ultrasound and we send them to the vascular lab and we have them ultrasound with their arm in full external rotation and abducted to try and look at flow. And then if we have concern, a lot of times we're just MRAing these kids. Quadrilateral space syndrome. This is bolded because you have to memorize this. So there are four structures to the quadrilateral space. So it is a space that is bordered superiorly by teres minor, inferiorly by teres major, which seems weird, right? Superior is minor, inferior is major. Just remember, major is not above minor, it's the opposite. And then medially, you have the long head of the triceps, and laterally, you have the neck of the humerus. So this is a structural space where people can develop pain. I guarantee you, I've probably seen this, and 99% of the time, I'm calling this rotator cuff tendonitis because they're getting tender around that teres major and minor, and they tend to have like this vague pain. They talk about distal radiating paresthesias that are worse in forward flexion, abduction, and external rotation because the axillary nerve travels through this space. But most of the time, it's just like this vague intermittent posterior shoulder joint pain. They tend to be tender to the touch, and then on And clinically, you want to do an internal rotation stretch and really strengthen those rotator cuff and scapular muscles, and they get better. I've never been asked anything on CAQ besides what are the structural borders of the quadrilateral space. Nobody seems to care anything else about it. So make sure you memorize those. The other big thing to memorize is the details of suprascapular nerve compression. So the suprascapular nerve travels through space where it can get compressed at two different locations. The first is the suprascapular notch, and the second is the sphenoglenoid notch. And if it gets compressed at one versus the other, clinically, it presents differently. So suprascapular notch can get compressed there because of a transverse scapular ligament compressing it. And if it gets compressed there, the suprascapular nerve will affect both supraspinatus and infraspinatus. So they will be weak with empty can and external rotation. If it gets compressed to the sphenoglenoid notch, it is almost always due to a ganglion in that location. So this is something you can pick up on ultrasound. And if you get compressed there, it's only the infraspinatus that gets affected. So you will just be weak in external rotation. I remember it because sphenoglenoid has an IN right at the beginning, and infraspinatus has an IN right in the beginning. So I try and remember sphenoglenoid is infraspinatus only. Therefore, the other one's got to be both. And suprascapular has super in the beginning, and so you know supraspinatus is in with it. People who have this issue can have follow-through pain with throwing, and then they're going to have weakness based on where the compression is. So a lot of times clinically you can start with ultrasound to assess the suprascapular notch and the sphenoglenoid notch and see if you see anything that compresses it. You can also try a nerve block and see if that helps, and occasionally you have to just do an MRI. So you will, if it's long-standing, you will develop atrophy. So here's a good picture of somebody who's gone on to get significant rotator cuff atrophy as a result of compression. Okay, that is it with shoulder. Has everybody had enough shoulder? Do you have questions about shoulder before we move on and try and tackle elbow? All right, moving on. Little league elbow. Here's another thing they love to ask about the elbow in terms of CAQ. I had a question about this year, so I actually added this slide. This is also good to think about clinically. So in the peds world, this is kind of drilled into our head. But for those of you who don't know it, make sure you learn it. This is the age where you get opening of the apophysis at the elbow. So we have multiple ones, and the mnemonic to remember it is crito. So it's capitellum, radius, internal, which is that medial epicondyle, trochlea, olecranon, and external, which is that lateral epicondyle. My youngest one just woke up. Good morning, kiddo. Must be nice to have a 5-day weekend. I know. I know. All right, get some breakfast. My kid is lecturing me that she's going to have a 6-day weekend because the forecast on Tuesday looks cold. Anyway, there is variability between genders. So these age ranges of opening are not specific, they're generalized. So capitellum opens at 1, radius at 3, medial at 5, etc. So if you can remember crito and just remember 1, 3, 5, 7, 9, 11, it at least gets you in the general range. Girls tend to open earlier, boys tend to open later, like most growth plates. So it's just important to remember this. Probably the best clinical thing to remember is if you're x-raying an elbow and you're like, oh my God, there are lines all over. I don't know if that's an injury or if that's normal growth plate. The benefit of most of our patients are they have another elbow that doesn't hurt. So send them back to radiology and take a picture of the other side for comparison. And then you can usually tell what's normal and what's not. And we use this a lot when we're looking at Little League elbow or if we're looking at possible fractures, because sometimes it's just not clear. So don't forget, you can always do an image of the other elbow. Don't be afraid to do that, just like we do for the shoulder. So Little League elbow is medial epicondyle apophysitis, is what I describe it as, but clinically, they have a large spectrum of problems that in the literature you will see referred to as Little League elbow. They'll talk about inflammation, loose bodies, OCDs of the capitellum, avulsion fractures, spurring. To me, none of that is Little League elbow. Little League elbow is really just clinically tender medial epicondyle that's developed because of overhead activity, and all those other things are specific. They are OCDs of capitellum. They are avulsion fractures. They are not Little League elbow. These people present with pain in the elbow. They can get some proximal forearm pain. Their pain tends to be all medial. It is insidious in onset. There's not a pop. It just hurts more over time. So you can start to separate out the problems based on your history. When you actually get an avulsion fracture, you will see that medial epicondyle hanging out in space versus when you have Little League elbow, it tends to be just more widening. And like I said, if you're unsure, you x-ray the other side. But an avulsion fracture is usually clinically obvious. It's, oh, I threw one pitch. I felt a pop in my elbow. My elbow got really sore. I had to come out of the game right away, and then I got some swelling. So the avulsion fracture presents like an avulsion fracture you think would present versus the apophysitis presents more like, oh, I had some elbow pain that got worse over time. OCDs of the capitellum make us really nervous. They are not a good problem to have. I've for sure seen more OCDs in the capitellum in gymnasts than I have in throwers. They cause lateral elbow pain. All of the force of the elbow is on the medial side where it's distracting, and that results in the lateral side of the elbow having compressive forces, and it develops lateral elbow pain when they're in valgus. You can end up with a flexion contracture if the OCD's been there a while and you're starting to get loose bodies. That is for sure a bad sign. That this is why we always x-ray elbow pain in athletes. So we start with an x-ray. If we don't see an OCD and we're concerned about an OCD, then we MRI them. And it can be a little subtle, but you're looking for kind of that irregularity right across from the head of the radius, where you have kind of that black hole or pothole appearance, just like you would in the medial femoral condyle of the knee. So it's something to really make sure that you're always looking for. These kids tend to have more lateral or anterior joint line pain. When you see it, you got to shut them down from throwing or gymnastics right away and MRI them. You don't want to push through this. The hard thing to do is separating an OCD from what we call Panner's disease. Panner's disease tends to happen at less than 10 years old versus OCDs, which happen 10 and older. So if they give you a case of a kid less than 10 with an x-ray of something funky at the capitellum, it's much more likely to be Panner's. And Panner's is just AVN of the capitellum. It happens completely randomly. We don't know why. It's a benign process. It causes some mild pain, but it typically always resolves with just rest. When you see Panner's, if you don't know if it's an OCD or Panner's, you MRI it and you ask the radiologist for help. And if you're not sure, you just have to shut the kid down and wait and see what the process does. So here is more like what Panner's looks like, would be like that far left x-ray with, oh, there's something funky going on in the capitellum, but it doesn't quite look like an OCD. And then the middle and the far right images are what happens if Panner's goes bad. So occasionally you can develop into a loose fragment, but it's pretty rare. A lot of times they start with a funky looking x-ray and then they just heal themselves in. So we watch these kids, but separating out OCD from Panner's on CAQ is really just an age thing. And then finally, once we go through the process of rehabbing people and we have kids, they're at the point of being completely pain-free, they have full motion, they have full strength, they've got that core stability, they've worked on their throwing form, then we want to talk about a functional return to play. And in the baseball world, that means an interval throwing program. These can be position specific, but you want to think about this like a return to running program where they're just gradually increasing their throwing in terms of distance and intensity. The annoying thing is learning how to get kids to follow this because it is so slow. And a lot of times the interval throwing programs are incredibly confusing. So everybody starts with return to throw, and then if they're pitching, they can progress to like a pitching specific program. And I'm going to flip to here's like a picture of a common one, right? So explaining this to like a 13-year-old on like how to, well, this one's specific for an 8 to 12-year-old. So even explaining this to a kid who's between 8 and 12 and getting them to understand how to do this is really hard. So there are different phases. We start with short toss, and then you're thinking about how to do this. So I always have kids start this in the context of physical therapy and have them do the first couple phases with physical therapy and have the physical therapist walk them through how to do this. There are lots of different interval throwing programs out there, so it's good to familiarize yourself with one. And I'm just going to flip back a little bit. So the soreness rules, I always tell people when you're doing these interval throwing programs, you want to start by doing a phase. And if you're not getting sore, you can advance to the next step each day. If you are getting sore, but it goes away quickly, you just want to make sure that you repeat that workout until you're not sore and before you advance. If you keep doing the same step and getting sore, you need to space out the workouts. So you just have to be really careful how people march through this. When you're talking about things like Little League shoulder, those kids oftentimes get shut down from throwing for close to 3 months. So to then get somebody back to throwing takes a while. So it's important to kind of walk through this and get kids throwing full speed at full distance really slowly. All right. We're going to walk through questions. It's audience participation time, which gives me an opportunity to drink more coffee. See if anybody was paying attention. Can anybody correctly identify the anatomic borders of the quadrilateral space in this fun list? This is almost always what the CAQ question looks like. Although sometimes they will break it up and they will give you the superior, the inferior, the lateral, and the medial, and you'll have to not only know the four borders, but you'll have to know which one's which. So did anybody memorize them fast enough to know which one's correct?
C.
Yes. So humeral neck is lateral, long head of the triceps is medial, and then you have both your teres major and teres minor, but they're opposite. Major you think is bigger, but it's inferior. Minor is superior. So you always want to remember it's the neck of the humerus, it's the long head of the triceps, and then both teres. Good job. This long-winded one, this is how one of my patients presented last year. It kind of cracked me up a little bit, but it kind of mimics one of the questions I had on CAQ. So the 13-year-old pitcher, he came in, he had done his spring tryout, and his coach said to him, you look like you could be a good pitcher. If you work on it, you're going to be my #1 pitcher in summer league this year, so please practice. So the kid talked his parents into buying him a bounce back screen. And as soon as the weather got good, he went outside and started pitching like 2 to 3 hours every day. And then he got pain within a week and showed up to the office within 3 weeks, not being able to raise his arm very well. He had diffuse lateral shoulder pain. He had pain in forward flexion abduction, couldn't go over 90 degrees comfortably. He was tender over his humeral head. He was weak in pretty much all planes, forward flexion, abduction, internal, external rotation. He had no instability. He had some pain with apprehension, but he wasn't like really unstable with apprehension. He had a positive Hawkins and Nears. So what do you think he has and what are you going to do about it?
B, Little League shoulder.
Yes.
Yeah.
Yeah. So, I mean, this is a great story for it, right? He ramped up his throwing. He was literally throwing for like 3 hours a day. I was like, you threw so much that you actually broke your own growth plate. Smooth move, kid. And he lost all of his summer season. So these kids are usually pretty straightforward. I got asked a really straightforward question on CAQ about identifying Little League shoulder based on the history and what you do about it. So correct, Little League shoulder. And then, so this was actually, I had a MSK ultrasound picture that went along with this. but they had a description saying, so they gave you the picture and you didn't even need it because it literally said, patient presented with the following MSK ultrasound image showing the sphenoglenoid notch containing a ganglion cyst. Which of the following physical exam findings do you expect? So although they gave me the ultrasound, I didn't actually need to know what was going on in the ultrasound. So which one do you expect if it's just compression of the suprascapular nerve at the sphenoglenoid notch only because of the ganglion?
D.
Did somebody say one I didn't hear?
D.
Yeah, so it's D. So you're just going to be weak at that external range of motion because the infraspinatus only is getting compressed. So going into my CAQ, I was a little nervous about all of the MSK ultrasound. And in the end, I had almost 0 on my test. I had this question, and then I had another question about a kid who presented with a dorsal wrist mass who had pain with extension of the wrist. And there was a picture of a clear cyst on ultrasound, and it said, like, what is the finding? So even as a dumb pediatrician, I could answer all of the musculoskeletal ultrasound questions with no issue. So they were all very straightforward. All right. Questions at all? I know it's a lot of info. This is one I'll email out to you guys so you can try and remember things, and maybe we'll build out a thrower's history form this week when clinic's slow. Everybody good? All right. Well, I hope everybody's roads were better today. They were awful yesterday. I hope nobody had trouble driving. And happy Friday to everybody. And that's it. Have a good day.
Thank you.
Thanks for joining us.